Oh, nice. But leave it for her shot. Let this be her shot. I'll be okay.
You sure there's another glass down there?
Thank you so much.
Well, somebody else will need it. This is yours.
Thank you.
You can have it
I'm good.
wherever you want.
Done now?
I just was changing font size because I can't see a damn thing without my glasses. And the glasses reflect on the down there, so I just have to get it big enough
Contacts.
that I can get far enough away from it.
I came down on the plane with
Morning, ladies and gentlemen. If I could have your attention, please.
Yeah, look at that.
Ladies and gentlemen, I think we'd like to get started. I think they'll turn it up if I keep talking.
I'm still young enough so
Ladies and gentlemen, I think we'd like to get started. If I may have your attention. Lots of terrific conversations going on here this morning. That's exactly what we want. But we also have some terrific information and presentations to share with you. Welcome to the Woodrow Wilson Center. My name's Jeff DeBelko. I direct the Environmental Change and Security Program and coordinate our Global Health Initiative. And it's a terrific privilege for us to be working with AID and a host of partners in today's event, the U.S. launch of the Lancet Maternal Survival Series. On behalf of our president and director, former Congressman Lee Hamilton, it gives us great pleasure to be able to host this event and to share with all of you, I think what you will agree are some tremendous insights in making a real difference in the world in maternal health. And so we're very lucky to be doing exactly what this nonpartisan, non-advocacy institute is supposed to do, which is bringing the insights of research and scholarship into the worlds of policy and practice and really making a difference so that either field can work and learn from each other, work with each other and learn from each other. For those of you who may be new to the center, just one word about the center. We are the formal memorial to Woodrow Wilson, so in that sense a nonpartisan, non-advocacy forum for this work. We try to do a lot of work on health, a lot of work on development, population, and also in the realm of the Environmental Change and Security Program, trying to understand these issues in broader foreign policy, development policy, security policy issues. So it's a thrill for us to have this discussion today. I should say we are thankful, as always, to have had a long partnership and long support from the Bureau of Global Health at AID, so we're very pleased to be working with them yet again. So I'm going to turn the floor over to Mary Ellen Stanton from USAID and Hidden to kick us off. So welcome all. One logistical note, when we come to the discussion, we ask that you wait for someone with a microphone to come to you because we are webcasting this live and the video will be archived and we want everyone online to be able to hear your terrific questions. So Mary Ellen, please, the floor is yours.
Thank you very much. I really want to thank the Woodrow Wilson Center for graciously hosting the U.S. launch of the Lancet Maternal Health Series published last week. On behalf of USAID, I warmly welcome the advocates, funders, UN, government and NGO partners, media, scientists, clinicians, programs, old friends, and new friends for the cause of maternal survival. I would also like to welcome and congratulate the series authors and the authors of the commentaries printed with the series and our other distinguished panelists. As you may have heard recently, Prudence died. Prudence Lemakono, mother of 3 small children. She died of childbirth complications in the Cameroon, and we learned of her death in 2 recent articles by Nicholas Kristof in the New York Times. There was really nothing unusual about Prudence's case. She's a poor rural woman with an obstructed labor. Well, there was one thing unusual. We heard about it. There were aspects of her case that relate to many things we'll talk about today: health systems, personnel, and money. But underneath it all, what she really died of is indifference. While there have been successes in reducing maternal mortality, from a global perspective, it is not nearly enough. And I'm sure that the discussions today will allow us to carefully consider our strategic choices informed by the evidence, as well as to re-energize us to combat the indifference that allows women like Prudence to die needlessly, leaving the catastrophe of motherless children and a world shamefully diminished by her death. Now I'd like to introduce Dr. Harshad Sanvi, Medical Director of Jhpiego Corporation, whose extensive clinical care, teaching, research, and advocacy for the cause of maternal survival, particularly reduction of postpartum hemorrhage, is appreciated by many in the far corners of the world. Harshad.
Thank you very much, ladies and gentlemen. It was February 1987, a normal day in Nairobi, Kenya. As the junior-most faculty member, I had the responsibility of managing the health care of women arriving that day at Kenyatta National Hospital. Some 30 women were waiting surgery for complications of unsafe abortion, and another 30 women would be seeking care for major complications during childbirth. 2 women had already died that day. It was a normal day at Kenyatta National Hospital. Across the city, it was not a normal day. The world's best experts and leaders were gathering in Nairobi to make a commitment to safe motherhood. As a naive and perhaps brash young physician, I had great hopes that in the years to come and on my watch, women would not die of uncontrolled bleeding after childbirth, from eclamptic convulsions, from sepsis, from ruptured uterus, and from the emerging new infection that we were barely aware of. It is now 20 years since we made that commitment to safe motherhood, and we have come a long way, but definitely not far enough. Today, we have the distinct pleasure to hear from a panel of distinguished and eminent speakers who will tell us how we have done, highlight progress being made, the challenges that remain and emerge. In Africa, when a woman discovers that she is pregnant, she will eventually find the courage to tell her friends and her family and perhaps a child that she's already had. And this is what she will say: I am going on a journey, and I know not if I will return. I am going on a journey, and I do not know if I will return. Today, in the lifetime of women in sub-Saharan Africa, 1 out of 16 women will not return from that journey, the journey of motherhood, the very journey that the authors of the Lancet series say women make to ensure the survival of the human species. It is now my pleasure to ask the panel of distinguished speakers to tell us how we can make this journey safe and when we can reassure Mama Mariam in Africa and Lakshmi Devi in Asia that she will indeed return safely from this journey. Let me invite, first of all, Niels Dullaert, Dr. Niels Dullaert. He is the president and the CEO of the Global Health Council, the world's largest membership alliance of public health professionals and organizations working in over 100 low-income countries to raise the attention, resources, and knowledge around health worldwide. Niels.
Okay, we can leave it up. Thank you, Arshad, and good morning. The Global Health Council and our members around the world, including many of you here in this room, share a common vision of a healthy and equitable world. and we're not shy about being an advocacy organization. A fundamental mark of a civilized society and deeply embedded in the teachings of all the world's great religions is the common willingness to minimize risks, especially for those who have the least power to protect themselves, and to share the burdens that are disproportionately borne by only some. Without this social contract, life is, in the words of philosopher Hobbes, nasty, brutish, and short. It is our moral and practical duty to minimize inequity and to maximize the benefits of knowledge and science for all. Flip a coin. If you're born a boy, your lifetime risk of pregnancy-related death and disability is 0. Flip a coin. If you're born a girl, it's something greater than 0, often considerably greater. We can't change the dictates of biology, at least not yet. So in avoiding the biological risk at a level of 100%, we men have a special obligation to work to minimize risk for all women. But that's not always the way it is in the real world. In Nick Christoph's recent heartrending article from a maternity in Cameroon, he described what I would call the two sides of the coin of shame: hopelessness and apathy. The young woman whose life was on the line and her family reflected that sense of hopelessness and fatalism that is the norm in many parts of the world today. The physician and the medical staff who refused to go the extra mile reflected the apathy. Like the two faces of the coin, they exist together and inseparable, and if you start to break one, you can help to break the other. When I first served in a rural clinic in Bangladesh 3 decades ago, I experienced firsthand as a young mother died under my hands from a ruptured uterus moments after I had prepped to carry out an emergency delivery. It was my first maternal death, and I've carried it with me ever since. I was stunned, standing a few feet away from the still warm corpse and decomposing fetus, at how matter-of-fact people, both family and staff, could be in the face of such monumental tragedy. But they lived in the world where that coin of shame was the common currency. How can we accept such inequity? Not just the bipolar inequity of female versus male biological risk, but the enormous disparities that exist in our globalized, interconnected world. A flip of the coin? If you happen to be a woman born in sub-Saharan Africa, your lifetime risk of dying as a consequence of pregnancy or childbirth is 400 times that of your sister in the United States. And even for those in the same country, as the flagship article in last week's Lancet points out, a woman in the poorest quintile in Peru faces 6 times the mortality risk with each pregnancy that she would face if she had the good fortune to be born in the same country in the richest quintile. This is simply not acceptable in a civilized world. Now, we've been talking about this for 20 years, ever since Alan Rosenfield and Deborah Main put the M back into MCH in 1985. We affirmed and reaffirmed its central importance in Nairobi in 1987, in Cairo in 1994, in Beijing in 1995, in the Millennium Development Goals in 2000. It's a pretty long gestation. But have we done enough? Clearly, unavoidably, inexorably not. The sacrificed lives of over 500,000 women a year and the diminished lives and futures of millions more who survived their pregnancy and delivery, but just barely, are testimony to our common failure. Over 10 million women have died since we started talking about safe motherhood. Enough. It's well past time to act, but a late start is better than no start at all. This event today and the Lancet series that it highlights marks a common recommitment to do what needs to be done to protect the lives of the world's poorest and most powerless women. What you'll hear today and read over the coming weeks in the Lancet represents three critical elements underlying meaningful action. First, facts. We know the situation, we can quantify its impact, and we can describe its distribution. This is essential to defining how pressing the need is and determining where and how we must act. Second, evidence. The world has not sat still for 20 years since Nairobi. Many interventions have been tried, scientific and epidemiological evidence has been amassed, and we're in a far better position today to apply what is solidly grounded in experience and fact and evidence to the world's needs. Third, resources. A common argument that has moved maternal health interventions down the priority ladder has been that they are too facility-based and too expertise-based to be affordable in a world where children die for lack of a few cents worth of vaccine. That reality and the assumptions around it have changed dramatically in recent years, and we're now able to speak of ongoing global health efforts in the context of billions of dollars, soon tens of billions, rather than the millions that seemed our ceiling a decade ago. This gives us enormous new opportunities to act. And in a nation that devotes $2 billion a week to a war framed as responding to the deaths of 3,000 innocent civilians, it is not inappropriate for us to insist that that number of innocent women dying every 2 days might deserve a commensurate response. So, what about the political will to act? This is where all of us must come in as advocates, and why it is essential that this is not simply an intellectual academic exercise, but a call to action that will carry with it real political momentum. Where there is great injustice in the world, there is equally great opportunity to rise to the moral challenge. This is the challenge we face today in addressing maternal deaths. All of us here and the global health community around the world are committed to meeting that challenge. We have the words on paper in the Millennium Development Goal number 5. The world's leaders committed to reducing maternal mortality rates by 3/4 by the year 2015. But any serious assessment tells us that we are not on track. When my wife and I worked in Nepal in the 1980s, we worked with safe motherhood programs to bring safe birthing kits to rural women who had no access to skilled maternity care. Included in this kit was a clean coin on which to cut the umbilical cord. You might call this the coin of honor. Our coin of honor, in contrast to the coin of shame, also has two faces: optimism and commitment. We are proud to be committed advocates for this cause. Our speakers today, the midwives of a healthy and equitable world, give this coin a special shine, and I am deeply honored to support their vital work. Thank you.
Thank you very much, Niels. Let me just say on behalf of the organizers that the copies of the Lancet publication, published in England and shipped out a few days ago, have had a delayed delivery. And so you've got some copies of the papers that were photocopies that were made, and I've been assured that we have the contact of everybody here, and those the originals will be shipped out to you shortly. I have the pleasure of introducing Ann Stars. Ann Stars is the Executive Vice President of Family Care International, where her responsibilities are the overall program development, strategic planning, administration, and fundraising. Ann Stars is currently serving as the co-chair of the steering committee of the Global Partnership for Maternal and Newborn and Child Health. And she's going to be speaking to us today and reviewing the history of the global Safe Motherhood Initiative. Anne.
Thank you, Harshad. Thank you, everybody. It's a pleasure to be here today and to share some of the memories and experiences that those of us who've been involved in safe motherhood since 1987 and, in fact, before then. As Harshad and Nils commented, safe motherhood really began before 1987, before that conference in Nairobi. The impetus really came in 1985 with two seminal events. One was the publication of the Rosenfield and Main article, Where is the M in MCH, that looked at maternal child health programs in developing countries and pointed out that the vast majority of the interventions that were included as those programs were really focused on children, and that the benefit for women was minimal. They identified what the causes of maternal mortality were and what needed to be done to address them. Later that year, also in 1985, the UN Decade for Women ended, and there was a conference also in Nairobi to mark that event. At that conference, someone from the World Health Organization first announced the fact that there were 500,000 women dying every year from the complications of pregnancy and childbirth, and asked the world what we were going to do about it. The people who heard that message and who spoke that message came together to organize and plan the Nairobi Safe Motherhood Conference in February of 1987. The aim of the conference, and of the initiative that it launched was to raise awareness of the numbers of women who are dying each year and to challenge key players, governments, UN agencies, donors, and the public health community in general to take action. The Safe Motherhood Interagency Group was established later that year in 1987 and organized a series of events, publications, conferences at the global, regional, and local levels in the late 1980s and 1990s that really focused on getting the message out there. Those activities, those events, established safe motherhood as a core element of reproductive health and identified it as a neglected element of national health strategies. We used to get the question a lot, well, why do we need a safe motherhood initiative when we have MCH programs? And the answer was always, where is the M in MCH? The activities of the Safe Motherhood Interagency Group and many other partners who were also working on these issues raised awareness about the scope, the causes, and the consequences of maternal mortality, and highlighting the disproportionate burden on women in developing countries. So the inequities between rich and poor countries, and as Nils pointed out, the inequities within countries between poor and rich women. So looking back, what have been the achievements and the successes and the lessons learned from the past almost 20 years? The Safe Motherhood Initiative was effective in raising awareness and in advocacy. The term, much less the concept of safe motherhood, didn't exist before 1985. And by 1997, there had already been a dramatic increase in the number of NGOs, non-governmental organizations, governments, and donors that had explicit safe motherhood or maternal health programs, probably from less to a dozen to hundreds if you include local NGOs. As Nils pointed out, the goal of maternal mortality reduction was incorporated into ICBD, into Beijing, and most recently in the MDGs. There have been significant advances in research and learning, both clinical and operational or programmatic. We know much more about what works in terms of specific interventions for dealing with the direct causes of death, like magnesium sulfate for eclampsia, like manual vacuum aspiration for unsafe abortion. And we're now testing new options like misoprostol for postpartum hemorrhage. And we know a lot more about how to deliver these interventions, how to make sure that women can get access to this care, as others, Corinne and Marge, will be talking about shortly. We've learned some lessons, too. The interventions and the strategies that were recommended in 1987, when the Safe Motherhood Initiative was launched, were comprehensive and included an emphasis on family planning, on improving health services, at both the community and referral levels, what we now call essential or emergency obstetric care, and an alarm and transport system. But the strategies that were most often picked up by donors and governments tended to focus on training of traditional birth attendants and risk screening, and neglected often those core health sector interventions. Safe motherhood strategies and plans at the national level were often enormous in scope and ambitious in aim. They recognized the importance of women's status, women's education, poverty, and their access to care, and tried to address those root causes of maternal death that were laid out by Mahmoud Fatala in his famous Mrs. X video. Unsafe abortion has also been a challenging issue for safe motherhood. It's a significant cause of maternal death. Globally, we know the average is about 13%. In some countries, it can be 30 to 50%. But programmatically, it's a different challenge in that the deaths occur during pregnancy rather than, for the most part, during or just after delivery. And it involves an unwanted rather than a desired pregnancy. So where are we now? I think we've been moving towards, and really found a middle ground in addressing these issues. By 1997, the 10th anniversary of the launching of the Safe Motherhood Initiative, we had evidence from a range of organizations, Columbia University and many others, on the ineffectiveness of the two approaches that had been most implemented, the TBA training and risk screening. That evidence was being widely disseminated and discussed and led to a real shift, a major shift in strategies, to a focus on health sector interventions, to a recognition that every pregnancy faces risk, that most complications are difficult to prevent and difficult to predict, and that the key issue is to ensure that women have access to care, skilled attendance during delivery, and emergency obstetric care when a complication arises. We now have a strategy that focuses on these interventions, a more nuanced approach to these critical needs. We also have a more nuanced approach to the issue of addressing the root causes of maternal death, those social and economic inequities. We recognize them and their importance, but now there is agreement that the way to address them is not through large-scale, massive safe motherhood strategies, but by working in collaboration with other organizations, with other sectors that can address these issues more effectively than doctors and midwives can. So where are we now? We all know that maternal mortality is a difficult indicator. It's hard to measure, it's hard to interpret. There are other indicators that show signs of improvement globally. Antenatal care has increased by 20% between 1990 and 2003. Skilled attendance rates globally have increased from 41% to 57% globally. And we also have a number of country successes that really show that maternal mortality can be reduced, that these strategies can be implemented. But there's no question that greater resources, action, and mobilization are needed. There are some signs of hope and promise. We have the Partnership for Maternal, Newborn, and Child Health. It's a new entity, still finding its feet, but it has enormous potential for advocacy and for concerted action by bringing together the maternal, newborn, and child health communities, by uniting around focused messages and focused strategies. Next year will be the 20th anniversary of the launching of the Safe Motherhood Initiative, and there is a major event being planned probably for October of next year. Stay tuned. So that will be another opportunity for really bringing the focus back to maternal health, looking at where we are, and hopefully getting the real high-level commitment that we need to move this agenda forward. We have a new MDG target as of Tuesday that includes reproductive health for all by the year 2015 as part of the overall goal for improving maternal health. I hope that this event and others to come will really be able to build on the momentum and knowledge that we've gained thus far and help us make effective use of these and other opportunities moving forward. Thank you.
Thank you very much, Anne. Anne has a commentary in the Lancet series. Let me now invite Dr. Karine Ransmans, who is an author in the Lancet series on maternal survival. And she has authored the paper on maternal mortality, who, when, where, and why. Corinne Ronsmans is an epidemiologist with degrees in medicine, demography, and epidemiology. She has been a member of the London School of Hygiene and Tropical Medicine, the Maternal program, since 1993, and its infectious disease epidemiology unit since 2001. Her areas of interest include the methodological and conceptual aspects of evaluation of maternal health programs and the measurement of maternal morbidity and mortality, and the understanding of the contribution of indirect causes, including HIV/AIDS and maternal mortality. Dr. Ronsmans has extensive work experience in Asia, Africa, and Africa. And so I invite Corinne to present the first two parts of the series. Corinne Ronsmans. Oops. There you go. You will control it.
Thank you very much. Good morning, ladies and gentlemen. It is a pleasure to be here today, and a pleasure for Marge and I to be able to present this series to you on behalf of the Lancet Maternal Series Steering Group and all the other co-authors who contributed to these papers. At the turn of this century, 189 countries endorsed the 5th Millennium Development Goal to reduce maternal mortality by 3/4 between 1990 and 2015. The purpose of this Lancet Maternal Survival Series is to help to reduce this preventable and unacceptable toll of maternal deaths by enabling countries to get on with what works. We would like to introduce you to the reality captured by this series using a story of a maternal death based on a number of real experiences. We would like to speak of the case of Martha. She was 25 years old at the start of her 4th pregnancy. Martha's household was one of the poorest in the village. For her previous delivery, she had needed an emergency cesarean section, which resulted in catastrophic payments. The cesarean had cost more than a year's income for this poor family. As antenatal care was free, Martha attended 3 times during her pregnancy. The nurse auxiliary at the antenatal clinic advised her that the delivery should be in a hospital because she had had a previous cesarean section. Martha indicated they could not afford this. The auxiliary encouraged her instead to come to the health center when she went into labor, from where she then could easily be referred if a problem developed. Martha went into labor around midnight, but she decided not to travel to the health center. Her mother-in-law waited till daylight before calling the traditional birth attendant. After a labor of almost 18 hours, the baby was delivered, weak but alive. The family was delighted to have a son, and many of you here today with children will know that feeling of elation. But the next morning, the baby died, and Martha started to develop severe pains in her lower abdomen, and her bleeding after delivery had not stopped. The family was not sure how serious this was, but after some time her husband decided to use the local bicycle ambulance to take her to the nearest 24-hour health center. Unfortunately, the ambulance was not immediately available, and so it was later that day before Martha reached the health center, 8 kilometers away. When they arrived, the midwife immediately recognized the seriousness of Martha's condition. She set up a drib for fluid replacement and told the family to arrange a local taxi to take her to the hospital another 2 hours away. When they arrived at the hospital, there was much confusion about where Martha should be taken, The maternity ward was very busy, and although Martha was visibly ill, it was 2 hours before she was seen by the only doctor. Martha needed surgery to have the retained placenta removed and to stop the bleeding. She also needed antibiotics, but there were none in the hospital. Her husband was sent to the local pharmacy for a surgical set and antibiotics, but first had to borrow the equivalent of £20 from a relative. He returned to the hospital to find Martha still bleeding and still waiting to go to the theatre. She collapsed and could not be resuscitated. Martha's body was taken to the mortuary next to the maternity ward. Her husband was told that she had died because of a retained placenta and was chastised by the nurses for allowing her to deliver with a traditional birth attendant and for delaying seeking care. Martha's funeral cost the family the equivalent of £80, her hospital treatment another £100. The doctors, nurses and midwives at the hospital reviewed Martha's case at their weekly audit meeting. They concluded that her death was ultimately caused by the delays on the part of the family and that no action needed to be taken on their part. They also stated that if she had delivered in a health center, the midwife might have been able to remove the placenta. Martha's case notes were mislaid after the audit, and her death was not recorded in the hospital statistics. The only record of her existence was the family she left behind, including 3 children, all under age 10. This is just one example of the 529,000 women who die each year. Our series focuses on maternal survival, but what we are calling for reaches far beyond the reduction of maternal mortality alone. Maternal survival is linked to the Millennium Development Goals for poverty reduction, female empowerment, and infectious diseases. The strategies we propose strengthen efforts for newborn survival, and maternal survival improves the health of the child and the welfare of the whole family. Maternal survival strategies also support health system strengthening. The problem of maternal mortality today is indeed large. A woman dies each minute, day in, day out. The difference in the burden of maternal mortality between developed and developing countries is cited as the largest discrepancy of all public health statistics. The enormity of the differences becomes apparent when comparing the extremes. It is hard to visualize what this means, and we have tried to do this by showing a field of 30,000 women. We can't show all their faces, so each woman is represented by a dot. For every 30,000 women in Sweden who reach age 15, 1 will die of maternal causes before reaching the end of her reproductive life, seen here as a red dot. In sub-Saharan Africa, this number is a staggering 1,875, or 1 in 16 will not survive the lifetime risks associated with pregnancy and childbirth. Such a marker of global inequality is shocking and is considerably greater than differentials for child and newborn mortality. When shown on a world map, and here you see the maternal mortality ratios, maternal deaths per 100,000 live births, The darker colors, representing the highest levels of maternal mortality, are clearly concentrated in sub-Saharan Africa and South Asia. Of the 529,000 maternal deaths each year, 240,000 occur in sub-Saharan Africa and another 205,000 in South Asia. Nearly all maternal deaths are in the developing world. Have we made any progress? The goal of MDG 5 is to bring a 75% reduction between 1990 and 2015. And what this slide shows are the levels estimated for developing countries in 1990 at approximately 480 deaths per 100,000 live births. A reduction by 75% in the year 2015 would have to bring this level down to 120 per 100,000 live births. This graph shows where we would expect to be based on the current slow rate of decline in developing countries. This is where we should be in 2015 if the MDG was met. The MDG is off track. The huge disparity in maternal mortality not only exists between countries, but also within countries, and the poor are hardest hit. This slide shows the maternal mortality ratio in 3 countries with very different levels of development and overall levels of maternal mortality. In Tanzania, the poorest 20% of the population are twice as likely to die as a consequence of childbirth than the richest 20%. In Indonesia, this ratio is threefold, and in Peru, a country with levels of maternal mortality that are half that of Tanzania, the difference between the rich and the poor is greater than sixfold. To better understand the interventions required to reduce these high levels, we need to look at when and why women die. Timing of maternal deaths is critical. This slide, using data from Bangladesh, shows you the maternal mortality rates by time since birth. And the first 2 bars are on, the first large bars are on the first day and the second day after birth. What this suggests is that most deaths cluster around labor or within 24 hours after delivery. Knowledge on the causes of death also drive the interventions needed. In sub-Saharan Africa, the left-hand bar, and South Asia, the right-hand bar, the largest single cause of death is excessive bleeding, represented by the red bar in the figure, followed by other obstetric complications such as hypertensive diseases or obstructed labor, indicated by the orange and yellow colors. Very few of these problems can be predicted or prevented during pregnancy, and all women are at risk of developing these complications around the time of giving birth, even those who have an apparently normal pregnancy. These problems, when they occur, can be prevented or treated during delivery or the immediate postpartum. Many proven single interventions are available and have been reported as effective in systematic or structured reviews. Although numerous such interventions have been assessed in randomized controlled trials, only 4 had maternal mortality as an outcome. This is partly because some common life-saving procedures, such as blood transfusion for postpartum hemorrhage, are so ingrained in routine practice and so visibly effective that to test them under randomized conditions would be unethical, and partly because of the large sample sizes required to determine the effects of interventions on maternal mortality. Nevertheless, effective single interventions do exist to prevent or treat virtually all life-threatening maternal complications. And here I'm giving just a few examples of some of these known effective interventions. The second paper in the series has an exhaustive table outlining all the interventions that have been proven to be effective. So, for example, postpartum hemorrhage can be prevented or treated through the active management of the third stage with oxytocin, the repair of lacerations, bimanual compression of the uterus, the use of oxytocin when bleeding occurs, and the manual removal of the placenta. Similarly, eclampsia and preeclampsia can be prevented or treated with calcium supplementation during pregnancy, magnesium sulfate to treat hypertension or convulsions, or by induction of labor. And another example is obstructed labor, which can be detected or prevented by advising women with a previous cesarean section to give birth in a hospital, by doing cephalic version at 36 weeks or later for malpresentation, by monitoring labor using a partograph, or by performing a symphysiotomy. These problems, when they occur, they can be treated, but they require considerable technical skills. For example, oxytocin can be dangerous when used incorrectly during labor, possibly leading to the rupture of the uterus. Similarly, the manual removal of the placenta can be a life-saving intervention at health center level, but technical skills are required so as not to induce more harm by pulling out the placenta too forcefully. Because of this, deciding where women deliver and who attends them is critical. We recommend a strategy in which women give birth in a health center with midwives as the main providers, but other attendants working with them in a team. This strategy will be routinely available to all women during labor and delivery and aims to maintain the normality of the birthing process with an emphasis on non-intervention and timely watchfulness. Women and their babies will be monitored during labor and for 24 hours after birth. Underlying this strategy are important principles of safety, primary prevention where possible, and early detection and management of problems. The treatment component includes all basic obstetric functions, from blood transfusions or apart from blood transfusions or surgery, which would be available at the referral hospital. The health center strategy is the best bet for maternal survival for a number of reasons. It is the most effective since skilled attendants can deliver the package of interventions that have been proven to be effective. It is more efficient than skilled attendants in the home or in hospital. Because health centers are already part of the health system, and a home-based strategy may be inefficient in terms of the skilled attendant's time and ability to cope with emergencies. Alternative strategies such as home births with a community health worker or traditional birth attendant are not as effective or efficient and may not be sustained. Most importantly, there is no evidence that traditional birth attendants or community health workers are able to provide most elements of an effective care package of interventions unless they are trained to the level of a skilled attendant. Health center strategies focusing on labor and delivery are acknowledged as the priority for reduction of maternal mortality, but the role of complementary strategies also need to be considered. We recognize the potential for 5 such strategies. The first of those is family planning. To say that without pregnancy there would be no maternal death seems obvious. But for women not wanting more children, preventing pregnancy is the most effective primary prevention strategy. The second of those complementary strategies is safe abortion. For women who are pregnant but who do not wish to continue their pregnancy, safe technologies for inducing abortion are available. If induced abortion strategies are acceptable in a country, they should be a priority. Third, antenatal care. Antenatal care has a role in the reduction of maternal mortality through birth preparedness and the identification of serious complications such as hypertensive diseases, provided that women can be referred to higher levels of care for the management of these complications. Other complementary strategies are those in collaboration with existing HIV and malaria prevention programs. HIV and malaria are a major cause of maternal death in settings where their prevalence is high. Most programs recognize the importance of integrating with maternal health services for effective scaling up. Both malaria and HIV programs benefit from the high uptake of antenatal and delivery care. The fifth complementary strategy is postpartum care. The health center strategy that we recommend needs to cover the very high risk period up to 24 hours after birth. The benefit for the mother of care beyond this period, which is what we call postpartum care, is not clear. And finally, it is often argued that improvements in women's general health should help prevent some complications and deaths. These arguments are most widely made for nutritional status, where improvement of women's hemoglobin, calcium, or iodine status is thought to reduce the risks of developing hemorrhage or eclampsia. The evidence so far, however, is weak. Improvement of vitamin A status has been shown in a randomized controlled trial in Nepal to reduce maternal mortality by 40% in deficient areas, but this effect is as yet unverified. The potential effect of nutritional interventions is uncertain. Marge?
Thank you very much, Karine, for that careful analysis of where we are today and what we need to do. Now I'm going to ask the second speaker, author on this panel, to make a presentation, and that is Dr. Marge Koblinsky, and she authored the paper entitled Going to Scale with Professional Skilled Care. Dr. Marge Koblinsky is the director of the Public Health Division of the International Center for Diarrheal Diseases Research in Bangladesh, responsible for strategic planning, administration, management, program deployment, fundraising, and implementing research programs. She is also the head of ICDDR's Reproductive Health Program and the senior scientist at the Department of International Health at Johns Hopkins Bloomberg School of Public Health. Since 1970, she has been a leader in safe motherhood and women's reproductive health at the global level, working in over 35 countries under USAID's Mother Care Project, Impact with donor agencies, Ford Foundation, and in Canada. Her focus is on country-level learning and translating research into programs, an effort she leads while based in Bangladesh. Dr. Marge Koblinsky. Just continue from here.
Hi, it's a great pleasure to be here, to see so many familiar faces, and to be back in a familiar place. So wonderful to see you. I'm going to be covering papers 3 through 5 of the series, and I do hope that by the end of the time we're here, we are able to get the supplements, which are stuck at the airport, I believe. Carrying on from where Corrine left off, let me address the question, where are we now? And what you would think is that we've made great progress. Half of the world's women currently give birth with a professional. But if you look back over the past 10 years, from 1992 through 2001, as you can see on the graph, you will see that in the urban areas, 70% of the women were already in facilities delivering with a professional. That was true in sub-Saharan Africa, which are the darker blue bars, as well as in Asia, the lighter blue bars. The problem is actually in the rural areas. And what you can see here on the lower graph is that only about a third of rural women have a professional at birth. This was true in 1992. It's true in 2001, particularly in sub-Saharan Africa. There has been some improvement in South Asia. It was 25% of women in the rural areas were able to access a professional for birth in 1992, and that's increased now to 35%. The use of health professionals also vary by the asset quintiles. And here what you see is that among the South Asian women, the poorest quintile, right through to the fourth quintile, are out of services during birth. Only those women who are in the richest quintile have access and utilize care. And even in that case, it's only about 50%. Sub-Saharan Africa has a very similar pattern, although it appears to be slightly higher here. And both of these patterns, where most women are outside of services, is called massive deprivation. Quite a different pattern presents in Europe and Central Asia, the top yellow bar, where you see that only the poorest are outside of services. This type of pattern is called marginal exclusion, where only the poorest are left out of care. Now, the barriers to care are quite well known, have been well researched for many years. They include cost, quality of care, either perceived or actual, and reluctance to use the care based on social or traditional barriers. The other barrier is professional care is just not available. While all of these barriers are similar across all countries, in countries with massive deprivation, we state that the biggest barrier is that professional care is simply not there. In countries of marginal exclusion, the major barrier is the cost. Also, quality of care and reluctance to use. But in this particular series of articles, we're going to be focusing primarily on cost and on the supply problem of health professionals. Let me first deal with the supply barrier. Rural India is a typical example of massive deprivation, and what you see here in the blue bar is the ideal for the OBGYN, the new nurse midwife, and the auxiliary nurse midwives. The Macroeconomics and Health Commission set that bar for the OBGYN at 2 OBGYNs per community health center. That community health center typically serves about 100,000 population. But the national norm set by the government is only 1 OBGYN for the CHC. The state, which actually has control over the health professionals, sanctioned positions at even half of that. That's seen in the cream bar. And those who are actually posted are even half of that. And living at position for the OBGYNs is only 6% of the ideal norm. You can see a similar pattern for nurse midwives and for the auxiliary nurse midwives, although they seem to do better in terms of the sanctioned position and those in place. But overall, in rural India, you only have between 6 and 25% of the ideal norm for providers in position. India is hardly unique, and in many developing countries you'll find that the shortage of human resources is huge. As stated in the World Health Report 2005, they advised that over 300,000 more health professionals were needed by 2015 to achieve a coverage of 75% at birth. Now, this is actually a conservative number because they use the birth rate for all of these providers, or each of these providers, at 175 births per provider per year. That's actually quite high. So these 300,000 is quite conservative. To support the new health professionals, 24,000 health centers are also needed, stated the World Health Report 2005. And this level was confirmed and verified by the AMDD project, which estimated that only 50% of the BEOC, the Basic Essential Obstetric Care facilities, were actually available in 9 of 14 countries that they assessed. How do we break this supply barrier? Decisions need to be made around 3 major factors: training, deployment, and retention. The questions that need to be addressed are, in training, who should be trained, for how long, how many births should they do while they're in training to achieve competency, and how will they be supervised? Deployment issues include where to provide the care. Should they be at home, at the health center, or at the hospital? Should they be provided in teams or solo workers? Should they be multi-purpose workers or dedicated? The retention issues includes how to maintain these health professionals in the rural areas in particular. Should incentives be provided? Bonding has been a standard method of the government to keep people primarily post-medical school in the rural areas. Should they hire locally instead of at national level? Should they provide retainers? Decisions with regard to each one of these factors has huge implications for future coverage. I'm going to go through in the next series of slides some options for scale-up. These are based on Bangladesh. Population growth for the 10 years between 2005 and 2015. We use the training capacity in Bangladesh, which is 1,000 providers can be trained per year. And we're using what we consider as a relatively conservative attrition rate of 10% per annum. The variables that we'll be looking at include the length of the training, 6 months versus 18 months. And the 6-month trained provider we call a midwife assistant. 18-month is the midwife. The place of deployment could be either the home or the facility. At the home, what we find in the literature typically, and when we observe in country, is that midwife assistants, these are relatively short-trained midwife assistants working solo to provide home births. And we will model them against facility-based births with teams. And these teams could consist of midwives, all 18 months trained or more, or midwives with the midwife assistant in a 1-to-2 ratio. The coverage of births per provider also change. And here we're going to change the births per provider from 20 births per year up to 220 births per year per provider. The 20 and the 50 that I'll be using are actually based on data from Bangladesh and from Indonesia, where we do have community-based skilled birth attendants, quote unquote. And the 175 and the 220 births per year are actually based on hospital data by teams of providers in Africa. So in the first set of models, I'm looking at 6-month trained midwife assistants. And I'm looking at the 10 years out, 2005 to 2015. In the blue bar, you see that they provide only 20 births per year. In the pink bar, it's 50 births per year. And what you see is that over that period of time, the 10 years between 2005 and 2015, you can get up to 10% increase in coverage. Looking at a second set of models, The yellow bars and the green bar, these are midwife teams working in facilities. The midwife teams in the yellow bar provide 175 births per midwife per year. 18-month trained midwives in the green bar provide 220 births per year per provider. And what you see there is that you can get the coverage up by 20 to 25 percentage points over the 10 years. Yet another example is to take a mix of providers. So you have teams in facilities providing care. A team consists of one midwife trained for 18 months and two midwife assistants trained for 6 months. In the purple bar, they provide 175 births per year each. In the brown bar, it's 220 births per year. And what you see there is you can get coverage up over the 10 years to 30% and 40%. So essentially the conclusion that we reached using this kind of modeling exercise is that it's far more efficient to be delivering through a team of midwives plus midwife assistants in a facility than it is to be a solo worker in the community. You can increase your coverage by up to 10 times by the health center approach with a mix of midwives and midwife assistants. Now let me turn to the cost barrier. Payments hurt the poor. This is hardly anything new to anyone here, but here's some data that we have from Benin, Ghana, and Bangladesh, where you see that the percent GDP per capita for a normal delivery in a hospital can be anywhere from 3 to 12%, whereas the cost of a C-section is 5 to 10 times higher than that, ranging from 11 to 138% in Bangladesh. That means that a family has to spend up to 138% of their GDP per capita to get this kind of emergency care. Such an effort would obviously drive a number of families into poverty, and hence the desire to use a facility when you have such risk that you may actually get a C-section is very low. To break the cost barrier, the financial barriers need to be reduced. Where they have been reduced, care seeking has improved. A promising approach that has been used in a number of countries is to remove the fees and fund the services through general taxes. Even in this case, the poor may need additional support for transport and drugs. So what's needed? There are 5 action steps that we are proposing. Number 1, a new era of strategic thinking needs to start now. Care during delivery is the priority for maternal survival. All women should be able to deliver in health centers with midwives working in teams, and we need to target the women in the greatest need, the poor and rural women in sub-Saharan Africa and South Asia. Number 2, it's quite clear that more health professionals for delivery are needed. Policymakers must make strategic health resource decisions in the 3 areas that I outlined: training, deployment, and retention. Very often what we see and what we hear is that people are very focused on the training, the 6 months, the 8 months, the 10 months, 18 months, and so forth. But essentially the decisions around deployment, where these workers go, is incredibly important and impinges very much on the coverage for the future. Obviously, investing in efforts also to retain existing staff is also quite critical. What we find and what we've used in these models is a 10% attrition rate. That's actually quite conservative. Indonesia, with its huge investment in the 55,000 trained midwives for village level, have now witnessed a 60% attrition. Greater financial resources need to be made available to protect the poorest families from these catastrophic consequences of unaffordable emergency care. National governments, as well as donors, need to increase their financial contributions, especially in the low-income countries, to fill the resource gap. Not very well understood is that the maternal and perinatal conditions, when added together, are a larger global burden of disease than HIV, TB, or malaria. And yet the investment in maternal and neonatal health in 2003 was only $663 million US. To achieve the universal coverage with a health professional, an additional $1 billion US is needed now, and it needs to increase to over $6 billion in 2015. We need to continue to strive for robust tracking of progress and accountability. Better data and information systems are needed to track the progress in improved services and in maternal health and survival. Coverage rates can be used as one of those driving indicators. This should not only encourage and monitor governments, but also donor commitments as well. Underpinning all of this effort is the political commitment, absolutely critical for the implementation. It's necessary to ensure this new era of strategic thinking in order for it to be translated into programs. And even though political solutions typically require speed and visibility of results, the maternal mortality reduction effort requires a consistent and significant effort over the next 10 years and beyond. The political solutions also require buy-in from professional groups, existing hierarchies and structures, including the electorate. And that's what we hope we are bringing here to this group, and that this group in itself will become a galvanized force to take this word further. Governments, donors, and the civil society need to be working together. Progress is very possible, and what we've seen and what I've heard in previous talks here are that there are examples out there. We know that in Sri Lanka, Thailand, and Malaysia, they've all reduced their maternal mortality over 50% over a 25-year period. They each used a skilled birth attendant effort, starting at community level, moving to facility level, and they had the political commitment and the long-term vision to put it in place. We're recommending the health center strategy because we think it's the best bet. We think it's effective and it's efficient. It will strengthen the health system by linking communities and facilities, as well as with the hospitals that can be used for the referral care. It will address the MDG 5 that the 189 countries have signed on to. What we continue to state is that we need to get on with what works. Let me just close by acknowledging those, and there are many, who have been part of this Lancet effort. The donors include DFID, USAID, number of universities, Impact, University of Aberdeen, the London School, ICDDRB, and the DFID Consortium towards 4x5. There were 20 authors. You only see 2 of us here, but there were many. Lancet editors and reviewers were incredibly helpful. Press officers and the Population Reference Bureau have been very helpful with these 2 launches. In London, we also thank Sandra Ribeiro and Elizabeth Anderson for their support. And here, Mary Ellen Stanton, Nazo Qureshi, Chris Thomas, Chris Deary, and Dave Burrows. We thank you very much for all of your help in putting on this presentation. The photos that we've used have been provided by the ICDDRB and the Impact Project. In closing, let me just come with a quote that's used on the Lancet supplement. This comes from the commentary by Ann Stars, stating, "The next 12 to 18 months will be critical for safe motherhood advocacy, offering an unprecedented chance to redress the errors of the past and take advantage of new opportunities." Thank you.
Thank you very much, Marge, for highlighting that we can program better the work of professional providers, especially teams of midwives, and for the need of commitment that is going to be long-lasting. Ladies and gentlemen, we will now move on to the two responses. And the first response will be from Lynn Friedman, who has a commentary in the series. And she's asking in this commentary if the meeting of the Millennium Development Goals 5 is an impossible dream. Lynn Friedman is the director of the Averting Maternal Death and Disability Program and professor of clinical public health in the Mailman School of Public Health at Columbia University. Before joining Columbia University, she was a practicing attorney in New York City. She served as the senior advisor to the UN Millennium Development Project Task Force as child health and maternal health component, and was the lead author for many of the task force background papers. Lynn.
Push this. I'm going to make it go without it. Well, thank you very much, Harshad. It is indeed a great pleasure to be here today. I begin with the same key point that the speakers before me began with. Maternal mortality is indeed the crisis, the tragedy, the shame that the previous speakers mentioned. But I would add one more thing, and that is that its very avoidability, the profound inequity that surrounds it, also make it a fundamental human rights issue that demands action and action now.
I'm sorry.
No problem. Action and action now. So let me begin by, in addressing action now, I really commend the authors of the series. There we go. See, this is the gender issue. I really commend the authors of the series for moving beyond just epidemiological analysis of all the possible causes and all of the possible effective interventions, for putting that out there, but moving beyond and insisting that there are a few key strategic choices. If maternal mortality reduction is the goal, then the priorities must be the intrapartum period, when most of the complications that kill women happen, but also the priority must be the challenge of scale and of universal access with equity. And so our challenge is not just when and the intrapartum period, but we need to give a different attention to scale, to access, and to equity. And so my main message here is the same one in the commentary that I co-authored with my colleagues Alan Rosenfield and Deborah Main, two real giants in the field. Our main message: saving women's lives in this way, that is, with a focus on the intrapartum period, being prepared to treat complications, is not just theory. It's not just abstract. It can be done. It has been done. There are tools. There are implementation strategies. There is a growing amount of experience in the field in countries throughout Asia, Africa, and Latin America. But there are also huge challenges. And as a respondent, I would say that one of my bigger concerns with the series is that with the attention in it largely focused on the issue of where to give birth, with the focus on this strategic choice about where to give birth, I think we have a challenge now to be sure that the bulk of attention and the bulk of resources in the follow-up to the series is not just focused on convincing people to make this strategic choice, but is really focused on making sure people can actually exercise these choices, that governments can exercise these choices. By that I mean that the attention and focus after the series, I think, needs to be on looking at the huge critical work of making sure that the health centers that are the center of the strategy offered here are actually there, that they're functioning, that they're providing services and providing them in a quality, rights-respectful way. These health centers described in the Health Center Intrapartum Care Strategy are meant to have basic emergency obstetric care and to be linked to back up referral hospitals that have comprehensive emergency obstetric care. So I would suggest in the series, even the alternatives that the authors put out there as alternative choices also include the need to have the kinds of health centers that are the center of the strategy they suggested, with basic emergency obstetric care to treat complications and backup. So I think there's a very important challenge to the field with the strategic questions about where to give birth, and especially how that relates to scale. But I hope that the energy afterwards will really be on getting out into the field and making sure that such health centers are there, that the professionals are there, that the whole ball of wax, so to speak, is working. And on that point, I want to just take a minute to reflect on the AMDD experience, and Marge mentioned it a little bit. In doing dozens of needs assessments in dozens of countries, what we see is that there often is more or less an adequate amount, maybe not adequate quality, of comprehensive emergency obstetric care facilities. But the health centers described in this strategy that are the focus of this strategy that should have basic emergency obstetric care are huge deficit in many, many parts of the world. And so I think this really needs attention. If this series focuses the world's attention and its resources on making sure that those health centers are functioning and accessible to everyone, the poor included, then I think it will have been a very, very important series. And that will be true whichever of the alternatives about choice of where to give birth is chosen by either women, and the series acknowledges that this is a woman's choice, or by governments who make choices about which of those to support. And so I want to finally say that my emphasis on that is not just on that the facility is there or that it's in a country's policies, but that it is functioning. And functioning is the key word. And I agree with the series authors that especially where there's massive deprivation, and those are the countries with the highest mortality, human resources is the key barrier. It has got to be a priority. It means skilled attendants, it means midwives, and I think it means other categories of mid-level providers doing so-called delegated tasks across not just normal delivery, but also the emergency obstetric functions. We also need to be clear. This is not just about training and equipment. It's not just about getting the inputs into the field and hoping that if you put them out there, then poof, everything works. It is really about the kind of attention. Some of the issues were raised in the series to management, to ensuring that the facility functions as part of a system, as part of what we've often called really not just an agglomeration of technical inputs, but as a real social institution that interacts with the people who it's meant to serve. So in this case, functioning should be the goal. Not just making sure we have all the inputs there, but that the facilities are functioning. And the experience, I think, in AMDD is that it can be done. It can be done relatively quickly. It can be done cost effectively. I'll just give one example. In Mozambique, in the province of Sofala, AMDD, working in partnership with UNFPA and the Ministry of Health, in less than 5 years, with a fairly modest investment, was able to upgrade what at that time were zero fully functioning basic emergency obstetric care facilities, that is to say, health centers of the kind that the series talks about, from 0 to 13 which by the minimums in the UN guidelines is an adequate number for the population of this area. At the same time, the number of complications in those facilities that were treated tripled. The case fatality rate was cut in half. And this same story could be told over and over in country after country after country. The story is repeated again and again. So it can be done relatively quickly, it can be done cost effectively, but let us be clear. Even if it can happen fast, even if it can happen cost effectively, this will take a long time to do at scale. I 100% back the series view that this is long term. We have to be talking about the kinds of at least 10 years in strategies, and then it requires serious, sustained investment. So our challenge, I think, is to take on this series, hope we get some energy from it, hope we're engaged with governments about making maternal mortality indeed the end goal of policies about maternal mortality. And then our challenge really, I think, is to get into the field, where women are dying every day, every hour, every minute, and to just get it done. Thank you.
Thank you. Thank you very much, Len. Our next reviewer is Dr. Koki Agarwal. Koki is the director of the Access Program, USAID's centrally funded 5-year flagship program in maternal and newborn health at Jopaigo, an affiliate of Johns Hopkins University. Dr. Agarwal is responsible for the overall management and the strategic and the technical direction of the Access Program. Prior to this, she was at with the Futures Group in the Center for International Health, and also the deputy director of the USAID-funded policy project. Koki is currently on the board, serves on the board of the White Ribbon Alliances, a global movement for raising awareness of and advocating for safe motherhood. So, Koki Agarwal.
Thank you, and greetings. I'd like to start with the story of Asha. Asha was born in a 6-sibling pool. She worked at home while her brothers went to school, wed at 16 to a man who seemed too old, but the household was good, or so she was told. Excited when she discovered, but knowing not, how to take care of her pregnancy as she ought. She relied on the elders and her spouse. Too late she realized he was just a mouse. When the pain started, the TBA was summoned. While Asha bled, the lady cautioned. For hours she poked and finally said, "We need to find Asha a hospital bed." "No," cried the mother-in-law. "All our babies were born at home. Asha can't leave," her mother-in-law droned. "She can perish for all I care," she screamed. Her husband stood quietly, as if in a dream. Into oblivion she slipped, the baby's cry barely heard. She gasped for breath, but could not utter a word. Let it not be a girl, for she too will suffer. If they did not care for me, would they care for her? All the issues raised in this snippet are highlighted in the papers that we heard about today. Yet, today I'm hopeful because the authors have done us a great service and have summarized for us what works for maternal survival. To some women in Africa, where the differential in surviving pregnancy and childbirth is the greatest compared to the industrialized world, the words maternal survival may themselves seem like an oxymoron. However, as concerned citizens of the world, and armed with the evidence that is provided in these papers, we have to rectify this impression. I'm truly honored and delighted to be able to comment on the Lancet series on maternal survival. And I would like to highlight briefly, from a program perspective, Some ideas that I've gleaned as new and some ideas that may have a new emphasis that I've learned from these papers. My colleague Lynn earlier demonstrated the potential for health center strategy and the readiness within her program experience. But I would like to focus a little bit on the human resource issue that is identified in these papers. A couple of the papers mentioned that over 330,000 midwives will be needed by 2015 to enable women to access skilled care. In addition, 27,000 doctors and 140,000 community health workers would be needed to be deployed by 2015. This certainly poses a challenge, but I feel that where there is a will, there's always a way. Linked to this human resource issue is the resource mobilization challenge, and the authors quote that an additional $1 billion in 2006 would be needed to end this inequality. And as Neil said earlier, put in perspective, that's just a few days of our work in Iraq. In India, the Federation of OBGYNs, the FOXI, received $5 million from the government of India as a part of their World Bank loan for them to train general physicians in anesthesiology and in cesarean sections, and to expand this to 20 sites within India. And this happened as a result of a small seed-funded project that was funded by MacArthur Foundation. In Afghanistan, under the USAID-funded project, community midwives who received 18 months of training, competency-based training, were deployed immediately and were found to be performing better than older midwives who had received 24 months of training. So there are several examples, I think, that demonstrate that skilled care can be provided and can be scaled up when there's commitment and there's resources to back up that commitment. And I can quote several more examples from the work that we do. However, we do need commitment, the political will backed by resources to make this a reality. And we need a commitment from political leaders, not just for the training, but that they will support the enabling environment for these skilled workers to provide to work in, including assuring adequate remuneration, security, and availability of equipment and commodities. The authors highlight the need to implement the intrapartum healthcare strategy, and I really thank them for putting their best foot forward. While we need the commitment and action to make this happen, achieving the ideal will take some time. Meanwhile, we need to ensure that we empower the communities to better utilize the services. Several community-based approaches have been demonstrated to change behavior and to improve the practice of evidence-based interventions. We have evidence that community-level distribution of misoprostol can decrease postpartum hemorrhage by 50%. The authors also provide evidence that family planning reduces maternal deaths by 25 to 40%. And we know that 200 million of the global pregnancies, out of that, 1/3 are unwanted. As part of the household to hospital continuum of care, we need to mobilize the community to utilize the existing community resources, to demand better services, and to pool in resources for emergency transport, and in general to be more supportive of maternal and newborn health care. Today we have heard of a strategy that is outlined in the papers that is evidence-based. We have available effective solutions to prevent needless maternal deaths. Let us not forget that behind every statistic that we read about in the papers, there is a woman who died in the prime of her life, leaving behind a child or children who have a much lower chance of survival. The authors present a compelling case of what works, and we have no excuse in delaying putting these solutions out in the facilities and in the communities to prevent maternal mortality. Thank you.
Thank you very much, Koki. And may I just request the panelists to come up now, and we will start our question and answer session. So Niels, Anne, Karine, Marge, Lynn, and Koki, come on over. While our panel is settling down, I did want to advise anybody who has a question to please use the microphone and state your name and your organization, and make some brief questions or comments. Okay, well, let's start. Yes, Lee, my dear.
Hi, I'm Catherine Skank-Iglesias from USAID. And one of the points, and I believe it was Marge's presentation, said something about the need for better information systems to monitor how things are going. And I wondered if you could talk a little bit about the advances so far and what you see as the need more specifically. Was it yours or Corinne's? I'm sorry, I couldn't remember.
Go ahead. Why don't you both, Corinne and Marge, answer that?
Is the question about more specifically which indicators we would like to suggest for monitoring?
Yeah, the indicators as well as what you see as the advances in tracking systems. You know, what is useful, what's been useful, and the management use of those.
In terms of indicators, I mean, a lot of added information has been gained. For example, in the recent project, the Initiative for Maternal Mortality Program Assessment. I mean, obviously, because we recommend a skilled attendant at birth in health facilities, this would be the prime indicator. The slight change from currently just measuring the % of births with a skilled attendant, we would like now to this being inclusive of the percentage of births with a skilled attendant in a health facility. Another indicator that people have used but perhaps not used sufficiently is the national cesarean section rate once you break it down by quintiles, by poverty quintiles. Work that we have done has shown across a large group of developing countries that when you look at the % of births with a cesarean section in the poorest quintile, a large number of countries have no cesarean sections amongst the poor. I know there is a problem with all-cause cesarean section rates, but we know very clearly that when women have no cesarean sections, surely some women are dying for lack of access to life-saving care. So, I mean, if we were to recommend 2 indicators of coverage, these would be the 2 indicators to recommend, particularly when broken down by urban-rural and by poverty quintile wherever possible. So these would be 2 indicators. You want to say something?
Yes, go ahead, please.
Well, could I just continue?
Marge, sorry, thank you. Yeah.
Could I just continue? What Corinne's talking about are indicators which we would like very much to have used. Having just returned from Tamil Nadu, however, I would also like to talk about systems of data that the governments can use. It was an incredible pleasure to see that within 2 months of work, the Tamil Nadu government actually knows what's happening at their health center level. They know how many have died, they know how many births have been in facilities, and so forth. This was a system for information that was put in place in 1994 by Danita. It's a scanning system. It's like what you did with your SATs back when. You know, when you checked things off with your little pencil? Well, essentially they do that at the health center level. They send it in on a monthly basis, and within 2 months, the government of Tamil Nadu knows what's happening. Absolutely phenomenal. I suggest that if people are really interested in information systems, it can be done. That system certainly did work well. The other way that they follow what's happening is the verbal autopsy. And they have a system whereby the commissioner for a district, and that's like your mayor, goes out with the medical team to the families to actually determine what happened during that death. And because of the interest at the political level of a mayor level of person, you get a lot more action happening. So number 1, they collect the data on the verbal autopsy. They have them within the year. And the mayors know what's happening. And because of that political involvement in the process, they also have much more action in terms of implementation. So that's on a large scale. Tamil Nadu is like most countries, or even larger than most countries. We're talking about an area with 62 million people. So it's huge. It can be done.
Thank you. Please state your name and your institution, please. Go ahead.
Yes, Dr. Mary Carnell from John Snow Incorporated. I'm just coming from Ethiopia, and I'm trying to put all of this. I appreciate everyone's comments, and I'd like to thank the Lancet, who maybe is not here today, for pushing this series, as well as the child and newborn that have come, and the nutrition that's coming, I think, in reproductive health. It's a tremendous help for all of us in the field, and I'll speak up. But I'm looking at Ethiopia. We're talking about 90 to 95% of women delivering at home. We're talking about 50% of women are more than 2 hours away from lousy health centers. Right now, this is 2006. We have 9 years till 2015. We've got 30,000 health extension workers who've been trained for a year, very little on skilled birth attendants in their training. What are we going to do, really, to make a difference in the time? I just don't see it right now. I'm just trying to see what practically we can do. Thank you.
All right. Well, maybe Marge, you want to start first, and then.
Oh, thank you, Harshad. That's always a pleasure. And Mary, if you don't know the answer, I'm not sure that I do. Because it certainly was very impressive to see that you were doing the training of the community health workers at the village level and linking them into services. And I think the geographical issues that are in Ethiopia and characterize those which are in other countries of sub-Saharan Africa are huge. I think what we're proposing in the Lancet strategy of the health center is that for the long term, where we need to head is a midwifery team located somewhere close to the community level. And we're organizing around a midwifery team primarily because they can get the birth coverage up, that they can work together in order to get that birth coverage up. When you have a CHW, even if that person is trained to be a skilled birth attendant, which is somewhat similar to what's happening now in Bangladesh, what we anticipate is that the coverage is going to remain low over a very long period of time. So the long-term plan is towards a team. Now, how that could be organized in Ethiopia is not clear to me, but I think your community health workers linking back to facilities, which I think they did do, to some extent, is a way of starting. I know also in Ethiopia you had the home-based life-saving skills. And again, that's an effort to begin the knowledge base at the community level of what are the problems and what they can do amongst themselves to begin to stabilize women before they try to move them on. But Ethiopia is obviously a major challenge.
Niels,
Let me just mention Tony Costello's upcoming commentary in this series. I think is very important here because, to paraphrase what he says, the optimal really shouldn't become the enemy of the adequate or the barely adequate. And I think we have to recognize that in places like Ethiopia and Nepal and many other places, it's going to be quite a long time before we get to the kind of system that's being talked about here, and we do have to have a plan B for those kinds of situations to at least make progressive gains in terms of care for mothers.
Lynn and then Anne.
I would just add that I think the trick here is that also the barely adequate or the shouldn't become the enemy of the optimal. And so, I think it goes both ways. And the trick is how to have a serious long-term strategy that we know will be effective and still try to begin meeting people's needs with interim strategies, but insist that governments be supported to have long-term strategies that take what we know are effective and cost-effective strategies at the same time.
Anne, please.
I think the other point that's not being made here is that there is an obvious short-term or medium-term strategy, which is to get those health centers that do exist able to provide good quality care on a 24-hour, 7-day-a-week basis. That's a very practical, realizable step. FCI, my organization, has been implementing a skilled care project in 3 countries in Africa that is very, very much following the approach that's recommended in this series. And we've had in Burkina Faso, for example, over about 2.5-3 years of intervention, 125% increase in skilled attendance and institutional delivery. partly because what generally happens in these countries in Africa is that the health centers, because they aren't able to provide good quality care, are totally underutilized. So getting them able to provide good quality care on a 24-hour, 7-day-a-week basis is an enormous step that then generates the demand. People start understanding and realizing that that care is available, and then you get the community involvement and community demand piece going so that there is a push from the community level as well as from local policymakers and decision makers to get more health centers built and really get that strategy going.
Donna, yeah, go ahead, please.
Donna Vivio from Japaigo. First of all, congratulations to all of the authors and to the Lancet on this series. I think I'd like to ask a question that's a little bit different from the ones that have been asked so far. The series talks about deployment of human resources, training, and retention attrition. And some of us in this room know that as fast as we train quality providers, skilled birth attendants, they are scooped up sometimes by industrialized countries that also are having increasing needs due to many things that we won't get into right now. So in an effort to get on with it, how are we planning, or how do you suggest that we engage some of these governments to perhaps address some of their own problems so that the need there is not as great? Thanks.
Thank you. All right. Koki, you want to take a shot at that first?
Sure, I can try. I think that that's a very, very important point, and I think that's why engaging the donors and having them understand that if they can also invest in this as part of their own needs, so that they're thinking about what their needs are. And when we make investments in training midwives in Ghana, they're also thinking of what their needs are. And we set up maybe centers of excellence that can serve both the needs, so that it's not just depriving the Ghanaians or the other African countries of the nurses and midwives that they have trained, but we are thinking ahead of time in terms of what the needs are from these developed or industrialized countries.
The joint learning initiative that has been conducted by the World Health Organization, Rockefeller Foundation, and others over the last couple of years has looked very hard at this set of problems. And obviously, the issues go far beyond midwives. In fact, midwives are probably the less mobile of the groups, whereas nurses and doctors are far more mobile, and there's a tremendous brain drain to the global north and even within the continent of Africa from less affluent to more affluent countries. Clearly, there's a very important advocacy issue here. When I deal with state health commissioners in the United States and they're talking about doing recruitment to get more third world nationals in to staff facilities, they haven't got the slightest idea of what that's doing to the health systems back there. So this is, I think, a place where the global health community and the domestic health community need to work closely together to raise awareness and to make this a sense of common responsibility.
Thank you. And if I can just add on that, I think sometimes we might have to change the paradigm and look at brain drain not as a problem but as an opportunity. There are many states, for example, Kerala in India, where they export a lot of human manpower, and these manpower come back and develop Kerala, and they have some incredible statistics. So I think perhaps we have to look at some different paradigms on this. All right. A lady at the back, please, yes.
Jill Gay, consultant, and thank you for a brilliant presentations and a fabulous series. And my question to the panelists is would you try and address some of the gender and sexuality issues raised by Koki Agarwal in her comments? I'll leave it open like that. I could elaborate, but...
Okay. Koki, and then maybe Marge and Karine can respond. So.
Well, I wanted to raise those issues because I think that they are the reality that we live with. And as part of the community response, I think the best lesson we can learn is to see how much we can empower the community to take action at their own level and to be more supportive of the needs of mothers and newborns. I think that that's why I feel that there's a need to make that joint investment. While we strengthen the health facilities, we also initiate some activities at the community so that we have a response from the community that will have an effect that we are looking for in the long term, where we have better utilization of services and a more supportive family environment where women can be taken to services in time.
March.
Yeah, and just to add on to that, it's not just the men in the family that we need to get to, it's the mother-in-laws, the sister-in-laws who also tend to make major decisions for the woman who's in labor. So it's a wider audience. The effort of, again, the home-based life-saving skills to address a birth team in the household is an incredibly useful way, I think, to begin to alert all in the household about the needs that the woman and the newborn may be facing.
I'm going to take a question from the other room. There are a lot of people in the other room also listening in. And this question is, I'm reading this question for the other room. The focus is understandably on basic emergency obstetric care at health center. So this can be thought to be a paradigm shift. But what do you do for where cesarean sections are needed in communities where there are high levels of obstructed labor and C-section is an important tool? So what is your suggested strategy? Corinne and Marge.
We did focus very much on the basic obstetric care level, on the health center level, because I think evidence shows that that's where the big challenge is. Work from AMDD has shown that hospitals tend to be available. I mean, assuming that that you need one referral hospital per 500,000 population, these hospitals tend to be available. What we specifically focused on, what we feel is the main barrier to access to cesarean sections, are the financial barriers. So that's why we made paper 4 an explicit paper addressing financial barriers to obstetric care. And that paper very much addresses the financial barriers to access to life-saving referral care are much greater than the financial barriers to access to basic health centers. So perhaps we haven't covered this sufficiently in the current presentation, but addressing financial barriers is probably the big challenge here.
Go ahead, Lynn, and then Anne.
Yeah, I agree with the comment from whoever, the anonymous comment there, that we really also do need to pay attention to the things that happen in comprehensive emergency obstetric care, including cesarean section. And I would just add that I think there's a lot in terms of making it available and accessible. In addition to cost, which is huge, there is also a huge human resource problem. And one of the strategies that increasingly is being used with great success, I think, is training mid-level providers to do cesarean sections. And we found in studies, for example, in Mozambique, to use the same example again, that something like 80–90% of cesareans in rural areas are already being done by non-physicians. And the retention rate is dramatically higher, as in something like 90% retention versus 0% retention for physicians. So I think there is a huge challenge on human resources for cesarean section, but there's some very good experience on ways to address that.
Anne?
I think another point to remember here is that focusing on that basic level, that health center level, is also a way to help ensure that women who need C-sections can get to the referral facilities more quickly, that the staff at that health center level, ideally with some sort of communications and transport system, which also needs to be part of the strategy, can identify the women who need cesarean sections or other higher level interventions much more quickly than people can at the community level in general, and also generally have access to the resources to make sure that women can get the transportation and get to those hospitals where the C-sections and other higher level care can be provided.
Go ahead, ma'am. Yeah.
Excuse me to stand up. My name is Doyin Oluwole. I'm Director of Africa's Health in 2010, a USAID-funded project. I speak on behalf of the voiceless African women. And I want to thank the Lancet for coming out with this series on maternal health. It's a big issue, as you have heard, in Africa. And we have heard that it is linked to poverty, to female empowerment, and improvement in health systems. But when you look at the tools that are available in African countries to make resources available to address these three, namely the PRSPs, the national plans of action, maternal health is not a priority. HIV, malaria, TB are priorities because these are diseases that are no respecter of persons. They affect men just as they do women. And I have always said, if it is men who are dying as a result of growing their hair or growing their nails, I'm sure maternal health would have been given greater priority than it has received in previous years. I'm wondering what it is that we want to do with this new Lancet series at country level to actually turn it into an advocacy tool in order to raise awareness and raise the commitment of governments to get maternal health into PRSPs and all other national tools that can make the resources available. And secondly, finally, I would like to plead for partnership in reality amongst those of us who are here. Let us stop saying that this strategy that works is AMDD strategy. It is USAID strategy. It is WHO strategy. Let us pick those strategies, high proven impact strategies that can make a difference to the life of an African woman like myself. Thank you.
Thank you. Comments? Perfect. Yeah. Niels, go ahead.
I think you're exactly right, and I would just note for this audience, given that we're sitting at 1300 Pennsylvania Avenue, that I'm deeply concerned as well about some of the consequences of the proposed reconfiguration of U.S. foreign assistance, in which maternal health issues really do not figure in at this point in the planning process into a resource allocation and decision-making process at the country level. There's a very real risk here that even if we get a sizable allocation of resources from Congress, that there won't be good mechanisms for spending it in ways that will save women's lives because of this policy and configuration decision. So I would just urge all of you to please pay attention to some of those issues as well as the money and the technical solutions.
Yes, quickly. I think to a large extent, you answered your own question, that there needs to be unity and support among the key actors, the key agencies at the global level and at the national level in support of the key messages of this Lancet series, and there needs to be action. You know, I talked in my presentation about what I see as some of the real opportunities with the partnership, with the focus on MDGs, with next year being the 20th anniversary of the Safe Motherhood Initiative, to really pick up the core messages of this Lancet series and get them out globally. But as you noted, very much the challenge here is to get those messages out at the country level. I think we all recognize that one of the problems that has afflicted the Safe Motherhood Initiative over the past 20 years has been sometimes, at least perceptions, that there are contradictory or inconsistent messages going to the country level. I remember being once meeting with somebody, the health officer at the UNICEF office in Kenya, talking to them about safe motherhood and being told, oh, we're not doing safe motherhood anymore, we're doing making pregnancy safer. Okay. You know, so I think it's really critical, as you said, that we not identify this as so-and-so strategy or this and that initiative, that what we focus on is what is being recommended, what needs to be done, and get the funds and the resources going for that.
Yes, please. I'd like to reinforce this point, because when we wrote the Lancet series, they were first going to be the Lancet Maternal Health series, because we recognized that the problem was much bigger than maternal survival, and that there is the broader maternal health and then the consequences that maternal ill health or maternal death might have on the family. However, as we wrote the series, we realized that we had to have a clear, consistent message. And what we realized in writing the series, that when you focus on maternal survival, your strategic choices become relatively simple. And unity in these strategic choices is then possible. So that's why we moved away from maternal health back to maternal survival. That's not because we don't recognize that the problem is much larger, but it's to create unity in the choice of strategies that countries can make in reducing maternal mortality.
And there, and then you next. Yeah.
Annie Clark, American College of Nurse Midwives. I too would like to thank the authors and the presenters. I was very gratified to see that in the second article of the series, it acknowledges that between a quarter and 2/5 of maternal deaths could be eliminated if unplanned and unwanted pregnancies were prevented. And the strategy that has been put forward, the health center being utilized for 24 hours postpartum, including delivery and postpartum, I wanted to ask, shouldn't we emphasize the importance of a mother leaving with a method of family planning chosen at that point in time?
Marge, go ahead.
Yes. I think that the 24 hours was primarily chosen around the timing of death. Obviously, the 6 weeks out, the normal postpartum, is when we've been talking about the family planning, and certainly the issues that Maureen Norton and her groups have been raising around birth spacing, incredibly important for the newborn as well. So yes, we do feel that postpartum family planning is a major effort that needs to be encouraged, given, I mean, it must be in place. And obviously that's a postpartum program that should be starting even before the woman goes into labor.
Very good. So go ahead. Microphone here, please.
Thank you. I'm Steve Harvey with University Research and the Quality Assurance Project. Most of the presentations today, understandably, given the burden of maternal mortality worldwide, focused on access, particularly financial access and geographic access. My question is about areas where there is reasonably good financial and geographic access. And I want to pick up on a comment that Marge made in her presentation about women who are reluctant to use facilities that are available to them, and often tied to what is commonly referred to as traditional beliefs or traditional conceptions of perceptions of what birth should be like. Corinne, when she gave the example about Martha and the story of Martha's death, noted at the end that the hospital staff concluded that there was nothing they could have done. Really, the fault lay with the family for not getting the woman to the hospital on time. And it's pretty typical to look at these situations as being the fault of the woman or the fault of the husband or the fault of the mother-in-law. But in the series, you also focus on issues of treatment within the health system. So in Marge's article, you talk about the problems of abuse and other reasons why women might not want to use health facilities that are available to them. And so I wonder if you would say a little bit about the relative priorities of educating, in maybe quote-unquote educating the community versus educating the health providers and the health system about quality health care in terms of treatment interpersonally and in the provision of services. Thank you.
Okay, go ahead, Marge, and then maybe Koki.
Another tough question. The relative priority between treatment by the providers and the family's sense of the treatment. Is that correct, Steve?
I guess so.
Well, educating health workers versus educating.
The importance of educating the health system and the providers as opposed to just saying it's the fault of the family.
In areas where you have massive deprivation, the human resource problem is massive, and trying to get available health providers is absolutely key. In those middle areas where you have countries which are already up to 40–50% use of services, you could do a lot with educating the providers to be much more sensitive to the needs of the families. Certainly the caring behaviors, which was an effort that was started many years ago, I think has not actually been seen as a major priority, but should be. The caring behaviors are absolutely key to families wanting to come in. It's also very obvious that the professionals themselves have to be taught about caring behaviors, that it doesn't seem to come very naturally, that when a woman is in labor she may have lots of pain, and she may need to be treated with respect, and with even more than respect, like a nurturing, monitoring effort. So yes, I think the caring behaviors and working with providers to ensure that the caring behaviors are part and parcel of their skills is absolutely key to ensuring that more families are seeking care. But the priority for me is in that middle group of countries which are already starting to use services, and the services are available. But again, we always sound like we're waffling. It should be part and parcel of the skills training.
All right, well, let me take somebody from the back, sir. Go ahead.
Thanks. Hi, my name is Paul Emer. I'm with USAID. Again, I'd like to thank the presenters here for this, for the work in the putting together this series and in presenting it to us here. But I'd like to have us reflect on who we are as well as an audience, and who you're presenting to, because I guess my point is that I think you've come up with a wonderful, technically and evidence-based solution to a problem that I think is a political problem. And so I think what I'd like to do is reflect back to you what you are going to do with this series, and I guess maybe Niels is one that could comment on this as from the advocacy approach. It's a political problem because it deals with issues of power, status, and the value of women's lives in the countries that we're talking about here. And I think the reason that we have the problem is because women don't have the power, they don't have the status, and their lives aren't valued. And until that starts happening in these countries that we've been talking about, not here in Washington, not here at 1300 Pennsylvania Avenue, but in those countries, then there won't be the accountability in those countries for the leadership in those countries to address these problems, and there won't be a demand for those kind of services in these countries. So again, I guess I'm joining with the colleague from Africa who made this, I think, the same kind of a plea, is that this has to be taken back to the country level. It has to be made political, because otherwise all of the wonderful technical solutions we have here are not going to lead to the results we want. And one of the things that I've learned in the last few years in my career is that there's great power in merging technical and politics, and this is, I think, one of the issues where that has to be done. Thanks.
Niels, why don't you address that?
Let me start. I think our challenge, and it's as true here in the United States as it is in the countries where maternal mortality is the highest, is dealing with what I call the three no's. The first of the no's is it's not important. Well, we have facts and evidence that it is important. That can be deployed at the global level. It can be deployed at the national level. Second no is there's nothing that can be done. It's hopeless. We can't do anything. Again, I think the evidence here helps us a great deal in terms of addressing that problem. The third one, though, is really political, and that one is nobody cares. And when I say nobody, I don't mean those of us sitting in this room and the people in the next room and the people doing the webcast. I mean nobody who matters. Nobody who gives. Nobody who gives. I'm sorry. I'm among friends here. Nobody who matters politically, who gives money to candidates, who gets people elected, or in other places who make sure that people's hold on power, which may have come through means other than elections, is maintained. That is key in terms of moving outside the box that we technical people usually sit in, and really engaging. And again, as you know very well, Paul, that's one of the things we do here, sometimes to our disadvantage, at the Global Health Council, but also the advocacy groups that we work with and that all of us work with in country. Our job is to push the boundaries and to make politicians and decision makers uncomfortable with the status quo, so that It becomes easier to address the first two no's if you're feeling like, well, maybe somebody does care and it would be, it's really not all that expensive compared to some other things that we may be spending money on. Let's just get on with it.
Lynn, go ahead.
Well, I fully agree that power is, very central to any solution to this. And there are a lot of issues at the country level and local level that are power related that need to be addressed. But I don't agree that we should absolve rich countries, donor countries of responsibility. I don't think any of the poor, high mortality countries have the freedom to do whatever they want, to implement the choices that they make. The policy making at country level absolutely involves both donor and, the countries themselves. That's one. And two, a country that has $11, $14, any of these numbers per capita a year expenditures on health will not meet these goals. I mean, meeting these goals, talking about scale, talking about universal access, talking about equity means making big additional investments. And I agree they have to be well spent. I agree there are issues at country level, but I don't think we can absolve rich countries and donor countries and say, first the answer is to solve the local political problems.
Thank you. And Anne?
I think that there are a number of challenges we face in dealing with this advocacy problem. I think one of the key factors here is getting a constituency and getting that constituency mobilized for this. It's something that we've been looking at within the Safe Motherhood movement, within the Partnership for Maternal, Newborn, and Child Health, looking, for example, at the HIV/AIDS movement and the ability of that movement to mobilize commitment, to mobilize high-level spokespeople, and, of course, to mobilize resources. And I think one of the things that we need to look at is look at things like the White Ribbon Alliance, which has been very effective in a number of countries at mobilizing women and women's groups to really push for changes, and in some countries to really play a very active role in designing interventions and developing tools that can help address this problem. So I think that's one key factor. I think that the availability of, or the agreement, a consensus around there being interventions that are known to be effective is also a huge advocacy tool. To be able to say we have a solution is a very important step in being able to go to decision makers and argue for investment of resources in these kinds of activities and interventions.
I'll take one last question. Okay.
Shauna Jansen from CCP. Thank you. My question actually relates to the dialogue that we're having currently. First, though, I want to thank the panelists and the authors for this stimulating discussion and incredibly important contribution to strategic thinking on safe motherhood. But my question relates, and also comment, relates to our ability to put this issue on political agendas within countries. And one of the things that came out of our project in Pakistan recently, we were conducting workshops with journalists to encourage them to start writing about and getting interest in safe motherhood and maternal and newborn health. One of our speakers was an economist and also doctor, and gave a talk about the economic benefits of investing in women and saving their lives. And the question that came to my mind in reading through the articles in the series is, what's the cost related to these investments, and what would it cost for a country to shift gears from the program that they're currently running to do a team-based approach in the healthcare system? So I guess my question and comment relates to, perhaps for the next series, to consider looking at the actual economic costs that these kinds of strategies entail, and what's the
Let's get a response from Corinne and Marge first.
We did have some costs that are in the fourth piece, but I think that there's one other issue. Having been in Bangladesh now for 2 years, I can see that the issue essentially is not so much the funding, which could be available. The donors are arguing, they have been arguing now for over a year, how to work together on supporting the maternal and newborn program. The issues are actually not only amongst themselves, but also as we work with the government on their program. The facilities are in place. There are some of the providers in place, although not all that are needed. The big issue happens to be retention. Nobody wants to work in the rural area. And how to ensure that the rural areas can be covered is extremely difficult. And while everybody is spending a lot of time on the 6 months versus 12 months versus 18-month issue, nobody's spending time on how to ensure that the providers will actually stay in the rural areas. And I think a focus on using some of the money which is actually already available to ensure the retention, the buildup of teams at the health centers would be absolutely key. So I think there are funds out there. I think what we need is some revitalization of the strategic planning that's in place.
Okay, I'm going to ask the panelists each to tell me one really quick message that you want to end with. Corinne, start with that. You've got a couple of seconds.
My message is that I think we know what works. If we can now all build towards all women to be able to give birth with a skilled attendant in a health facility.
And?
Move on from today towards it.
You got a chance to say...
Sorry, I thought you were going to do Marge next. I thought I had a few more seconds there. I totally agree with Corinne's comment. I think if I had one message, I guess what I would focus on is the human resource issue. We know that in Africa accounts for 14% of the world's population, for 25% of the world's maternal deaths, and less than 3% of the world's health workers. I think that says it all right there.
Right, Niels?
Those with the means have the moral obligation to help those with the needs.
Koki?
I feel we are sitting here with champions, and I want us all, and myself included, to leave as being a champion for this cause and to do everything in our power to make a difference.
And Lynn?
The focus needs to be in the field, in the countries, on the ground, where women are dying, to make sure that services are available and they work.
Well, thank you very much, the panel.
Marge.
Oh, Marge. Okay, you get the last one.
I got out of it.
Sorry.
The rest of us had to suffer. Marge has to do her bit, too.
I was hopeful. Context counts, and being in the countries and working with the governments is absolutely key to getting it in place.
Okay, thank you so much. And I'm going to ask now Ann Tinker to come and help us look at the way forward. Ann Tinker is the director for Saving Newborn Lives initiative at Save the Children. And she has had a large amount of experience in managing many, many programs previously with the World Bank and with USAID and many other places, and has led the Safe Motherhood movement for many, many years. Ann Tinker, let's talk about the way forward.
Well, this has been an excellent panel and a very exciting series. I'll just have a few comments to make. The report is very clear about the biggest health challenge for women, and that is during birth and the following 24 hours. The recommendation for health centers staffed by midwives is absolutely key, as long as that center functions as part of a health system that includes the community. What are the priorities for action now? One is on the supply side. We need to provide women with access to skilled birth attendants during childbirth at these health centers with referral capacity for complications. But there's also a demand side that needs to be addressed, and that is improving self-care, improving community practices, and increasing appropriate care seeking. What's the best delivery strategy? I think it's important to understand, as a result of the report, what strategy might be analytically best to reduce maternal mortality specifically. In policies and programs on the ground, as some of us have mentioned, this goal needs to be taken in the context of politics, economics, and the social fabric of the society. So we need to think about two continua. One is the continuum of life cycle care, and that is looking at women and children from the perspective of pre-pregnancy to pregnancy to childbirth to postnatal period and childhood. The value of this approach is that it recognizes that maternal health is more than survival, that maternal health significantly influences newborn outcome, and that newborn health is the foundation for childhood and later life. The other continuum of care is by place, and strengthening and linking the health system, the health center as we've been talking about here, from household and community to that health center and hospital. This recognizes that community-based interventions promote healthy practices and the demand for care, and that a well-functioning referral chain increases the effectiveness and efficiency of the overall health system. Equity also needs to be a driving principle, and this calls for doable strategies to reach the poor and those with limited or no access to formal health services. If we do believe, as I do, that maternal health is a human right, we have two simultaneous challenges and should not settle for less. The first is to reach the current generation of vulnerable women and children, most of whom are dying in communities. The second is to build the infrastructure we've been talking about today to ensure that their younger sisters have better options ahead of them in the future years. The nexus of maternal, newborn, and child health is clearly the intrapartum and early postnatal care period for the mother and baby dyad. And a lot of what we've talked about this morning really has focused on that intrapartum period specifically. While our goal is for every woman giving birth to be attended by a professional with midwifery skills and have access to emergency obstetric care for complications, those skilled attendants must also be trained and supervised to resuscitate asphyxiated babies. We must also ensure that each new mother and baby receive essential postnatal care. Research is critically needed on the optimum content, timing, and who will give this postpartum care and where. The demographic and health surveys in 23 African countries found that 2/3 of women in Africa in these countries give birth at home. Only 13% of those women ever received any postnatal care. Even when women deliver in facilities, we know they are usually discharged early, and therefore follow-up postnatal care is needed close to their homes. Save the Children, Saving Newborn Lives program is working with many partners, some of whom are here today, to strengthen the evidence base for early postnatal care, given that over 3 million newborns and mothers die during that first week of life. In fact, WHO still recommends historically that postnatal care be given at 6 hours, 6 days, 6 weeks. We know that isn't sufficient. We know that isn't evidence-based, and that recommendation has to be changed. So let's get to the way forward. We know that there are successes that we can build on. As has been mentioned, there's an MDG now for maternal mortality and skilled attendants that puts maternal health higher on the development agenda. There have been technical advances in how to manage hemorrhage, eclampsia, obstructed labor, and infection. We also know from some of the comments by Marge about the success of improving health status in countries like Honduras, Nicaragua, and Vietnam, even though these countries have very limited resources, and countries earlier like Malaysia and Sri Lanka. There have been national roadmaps developed for maternal and newborn health in 35 African countries, thanks to initiatives by Doyen Olawale. There are also the global, regional, and national partnerships, and Anne mentioned the Partnership for Maternal, Newborn, and Child Health, which has the potential for increasing advocacy, resource mobilization, and coordinated action at country level. So the next steps are to reach consensus on some key advocacy messages. These include the economic and equity arguments, since, as we've already said, women really aren't our target for advocacy. They don't want to die. It's the people who make the decisions around them. We also need champions in developing countries for maternal health, and we need to get and use data effectively and strategically. We need to generate genuine and sustained commitment by governments, donor agencies, and civil society from top to bottom. We need to build alliances and exploit synergies rather than letting old dichotomies divide us. Develop optimal strategies for mother and child, community and facility, childbirth within as the nexus within a continuum of care. We need to reach unity, if not unanimity, around technical interventions and strategies, and recognize that key players build from different strengths and resources and will bring those to the table, which should promote a complementary, if not equivalent, approach. For example, the World Bank can help build infrastructure and train staff. NGOs can help at the community level. We need to find effective ways to reduce the geographic, cultural, and financial barriers to care, including eliminating user fees and ensuring insurance that covers basic maternal and newborn care. We need to support country-specific initiatives and action. This may include simple packages to reduce deaths in poor communities while simultaneously working to achieve higher coverage through training, deploying and retaining midwives, and building facilities over the next few years. Sub-Saharan Africa and South Asia have to be our priorities. That's where the rates and the numbers are the highest. An immediate step is to use this Lancet series as a platform for advocacy in countries, and I do hope that there is a strategy to have launches in countries, which is what we tried to do in earlier similar series on newborn health, because as everyone has said, it's really at the country level where the difference will be made. If I could just have one last thing to say, Harshad, it would be, it's high time and beyond time to declare an emergency. Let's not continue to let our sisters and daughters die needlessly. Thank you.
Thank you very much, and I think you will all agree with me that this was an excellent panel. Please join me in thanking all of our panelists. And I think if I just want to wrap up with one thought, I think that we've got some really incredible data and information. And perhaps, as I think it was Niels who said, let us go out and use this information and make people who make decisions a little bit uncomfortable with the status quo. Ladies and gentlemen, thank you very much, and let's give a big hand to our
Thank you, Harshan.